Sir, Dr. Manish Pandey, sir, please come on stage.
Dr. Manish, Dr. Jaskar Raja, Dr. Manish, Dr. Jaskar Raja, सर यार जस्कर को उठाना पड़ेगा.
Thank you, everyone. Now, I would like to invite the chairpersons, Dr. Manish Koirala, sir, Dr. T. Ganesh, sir, for chairing the sessions on surface-guided radiation therapy symposium. I would like to invite Dr. Prasad Raj Dandekar from Sir H.N. Reliance Hospital, Mumbai, for the first session. So please come on stage.
So thank you very much for inviting me here in Delhi, and it's a pleasant change. It's very pleasantly cold outside. We have a little bit of a technical problem. My laptop is not connecting to the system, so we're going to take a couple of minutes to sort it out. So just stay on with us for a couple of minutes. Okay. I'm not sure how to do that. Is there anyone from your team who can help us?
क्या होता है लैपटॉप में ना हम लोग प्रोजेक्टर के लिए यहाँ से कुछ होता है लाइक नॉर्मल विंडोज़ में एप्पल का मेरे को भी आइडिया वन सेकेंड.
Is there anyone here who is an Apple expert? We have an Apple technical problem.
Dr. Irfan.
I don't remember which function we had to press to start the projection. Do you remember? Do you know? I think it's some F5 or.
No, this is एक second. Auto हो जाता है.
I mean, normally it happens automatically. I don't know.
Which is this? नहीं नहीं. एक just a second ना. systems it said arrangement.
डिस्प्ले चेक बॉक्स
Which one? It said normally तो यहाँ पे बना रहता था, आपके में है नहीं. I don't know why it is not there.
आप लैब लेते हैं नो नो चीफ असिस्टेंट
Okay, till the time we get over this crisis, I call upon Mr. Mike Talamer, who is the chief physicist from the Centura Health at Colorado, USA. Having an experience of over 15 years in the field, he had earlier worked at Rocky Mountain Cancer Center and past president of WPM of Rocky Mountain chapter also. He has been utilizing SGRT system since 2008 for more than 10 years and has been able to compare it with other systems such as BrainLab, CyberKnife, and also Varian RPM. Today he will be speaking on SGRT for every patient. Mr. Mike Talamer, please.
He'll join via telecom.
Oh, he is going to join us via telecon.
इसको यार की लाइट बंद कराओ ना दिस हेड दिस लाइट
Mr. Mike is going to join us from Colorado, USA. Hello? Mike,
Hello?
are you able to hear us?
I can hear you.
Your voice is a bit, we are not able to hear you properly.
Can you hear me now?
Yeah. Yeah.
Okay.
So you can tilt your camera because your head, yeah, now fine.
That working?
Yeah, fine.
Okay.
Yeah, hi Mike. Just want to check with you, would you be doing the presentation or you would be saying next so that my people will just change the slides?
Okay. Yeah, I can just tell you next slide.
Okay.
And
You can just say next
We'll go from
and
there.
then the slides will go. Yeah, done. Thank you.
okay.
So we can start? Yeah.
Okay. All right. Well, good evening, good morning. I'm not really sure where I'm at anymore. My name is Mike Tallhammer. I'm the Chief of Physics for Centura Health here in the state of Colorado in the U.S. And I've been asked to kind of give you a general kind of flavor of how SGRT is changing how we do radiation oncology here at Centura and how it's kind of moving beyond just a setup tool or a radiation oncology kind of IGRT-based system to moving beyond that into kind of a patient-guided radiation therapy experience as a full practice management type of tool. As far as disclosures, these are my disclosures. But before I can tell you kind of how we change our practice, I kind of have to give you a feel of what we're treating with this type of technology. We have 5 radiation oncology centers that are using this right now. We have 9 radiation oncology centers total. The other 4 are looking at purchasing this technology within the next year as they upgrade their LINAC fleet from IX series LINACs to the TrueBeam series LINACs. We use TrueBeams across all of our centers. But we're treating essentially 100% of our patients with SGRT. I say 100%, it's more like 98% because of some palliative, clinical setup electrons that don't necessarily require it. But we are completely tattoo-less. We set up all of our patients using SGRT. We use no marks. So essentially every patient that comes through our centers is getting an SGRT type of setup. We don't use the lasers in the room other than for gross positional verification on certain types of treatments, but overall every patient is set up using SGRT, and then it's used in various different aspects. As you move up this tree of complexity, we usually refer to it as you go from standard palliative cases and things like deep inspiration breath hold breast to other things like trigeminal neuralgia and those types of indications which require a more integrated approach with the SGRT system. And so you're looking at gating, breath hold for SBRT, posture correction for head and neck, and other lymphoma type cases. And so it's used in various capacities, but it's always used as our primary setup tool and our intrafracture management tool. When we talk about moving up that from least complex to more complex types of treatments, we talk about different requirements in our quality management program. And you can't really have a quality management program without talking about some aspect of information. As you can see on this slide, essentially this iPhone has some quality issues, it's very apparent, but the information we have doesn't give us the total aspect of what that quality issue might be. We know that the outside is damaged, but it doesn't tell us anything about the microprocessors, about the operating system or the user code that might be operating. That may all be intact, but there are other quality issues going on. And so we need to be able to process information. And these SGRT systems are very good at providing not just data, but information and actionable insights to our physicians. The goal of our physics teams is always to turn the data that we collect into information, and then that information into those insights for our physicians to actually practice on a day-to-day basis. And so as we move through radiation oncology, as we've now moved into 2018, and we have TrueBeam Linacs giving us updated information about every moving axis in every 20 millisecond increments. We have SGRT systems giving us the actual position and posture of our patient every 6 to 7 times per second. We have lots and lots of data, but what we like to do is turn that data into information that our physicians can use then to gain insight about not only the way we manage our patients, but the way we're treating our patients each and every fraction, and then move beyond that even to predicting states of those treatments before they happen to our patients. We don't want just a tool that says, this is how you did. We want a tool that tells us, this is how you're going to do moving into it, so there's less uncertainty about what we might be doing at the time of treatment. We've already answered those questions up front by gathering the data ahead of time. So next slide. I'm sorry, I keep forgetting to say next slide. I should be on slide 4 right now, or 5. I apologize. I'm running through my slides on this end and keep forgetting to say next slide. So are we at slide 5?
No problem, sir. I'll just put on slide 5.
Okay, I apologize for that. I'm
No
talking
problem.
away here
No
and-
problem. Just
I'm not
keep
used
on.
to having to say next
Yeah,
slide.
yeah, please.
But so where do we go from here? Essentially, we have all this information, or I'm sorry, all this data, and we need to turn it into information. And the physics teams and the physician teams and the therapy teams were inundated with all of this information on a day-to-day basis, and now we would like to take that and turn it into something. So if you go to the next slide, SGRT is an observer-based pattern. And what that means is in computer vision systems, they're widely used across a number of fields, not just radiation oncology, to basically gather quality control system data. They gather it in real time, and they also process a large amount of that data in real time and can give the user or the monitor, in this case, some sort of actionable insight in a real-time fashion. And so what we'd like to do is take our SGRT systems like AlignRT and further integrate them into our practice from a radiation oncology standpoint so that we're getting this real-time information, so that we're changing the way we practice and changing the way we think about quality management and the way we treat our patients. Next slide. The way we do that typically in radiation oncology in the past is we do everything from a commissioning-based standpoint. So we have a new system, we bring it into our clinics. That new system is then commissioned by the physics team, and that's largely determining and measuring the accuracy of the system, determining its limitations, developing different QA schedules that we may need, whether it's daily, monthly, annual type of testing, and then developing essentially a set of operating procedures for our clinicians to say, if you operate within these parameters, this system is accurate to do X, Y, and Z for our patients. SGRT systems and AlignRTs specifically move into more of a future-based approach to radiation oncology that is more of a performance-based validation of your system. It's an assessment tool, it's a setup tool, but it's largely looking at not only what are we doing on this patient, but on this population of patients, how are we managing these patients? And it's an assessment or an ongoing process improvement of those types of treatments. And so the more you get SGRT integrated into your workflow, the more it becomes kind of a source of truth for what's actually happening at the machine, rather than what we calculated as physicists back just simply at the time when we commissioned it and entered the system. So it's a daily performance validation under very clinically relevant conditions. Next slide. Because it is that way, I in my practice typically will meet with my physicians at least on a monthly basis, and this is kind of a phrase that I oftentimes use is you can't unknow something. SGRT and AlignRT specifically is telling you lots of things about your process, the end-to-end quality of your process, how your patients are doing, whether your patients are changing, whether that needs to be addressed from a clinical plan standpoint, or whether that needs to be addressed from a setup and monitoring standpoint. And so you can't unknow these things, but you are forced to kind of address that when you have SGRT integrated into your process. So as you integrate SGRT into your process, and AlignRT is watching your patients on a daily basis, you're now getting a series of information that you either have to act upon or you have to actively ignore. You just can't simply unknow it. So next slide. One of those ways that we look at it is, and actually it's been published on, is using SGRT to determine margins and tolerances. SGRT can be used to determine the systematic and random errors in any type of setup. So specifically what we look at is SBRT, SRS types of setups, look at the intrafraction and the interfraction motion evaluation, and that allows us to statistically derive planning margins rather than just calculating them from the accuracy data that we had as physicists. We can actually calculate planning margins that are a total planning margin as it relates to the end-to-end skill set that we have within our clinic. So a physicist doing a plan end-to-end with a phantom may be completely different than what you have with your therapist doing an end-to-end with a live patient. And these SGRT systems are gathering that data on a daily basis on every one of your patients. And now you can say, okay, well, is our immobilization system adequate to keep a 3 millimeter margin for SBRT lung? It may not be. It may be if a physicist is setting up a phantom within that immobilization system, but if you have a living, breathing, moving, non-compliant patient in that immobilization system, is it truly adequate enough to keep a 3 millimeter margin? Most of the time it is not. And so what we'd like to do is use these systems to determine those planning margins. The other way we like to use our SGRT systems is an ongoing evaluation of our training efforts. It limits our type 1 and type 2 errors at the machine as far as false positives and false negatives. We don't, as a physics team, we run really pretty tight staffing wise. And so being called to the machine every time there's something and it end up not being an issue is time that is wasted for us, and not wasted in the aspect of making sure that there's good quality treatment, but it's a troubleshooting a problem that wasn't a problem. And so what we can do is we can use the statistical output from our SGRT systems like AlignRT to evaluate the true tolerances. What do we operate at? Can we keep a breast at 3 millimeters? All of our breasts are kept at 3 millimeters at our institution, but I've done consulting work at other institutions where they keep their breasts at 5 millimeters. They're getting good clinical outcomes, but they operate in a 5 millimeter window. We operate in a 3 millimeter window. We've also been operating with SGRT for many, many more years. And so as your skill set gets better, say you introduce SGRT or say you introduce SBRT, maybe at the beginning you need a 5 millimeter tolerance or a 3 millimeter tolerance, but as your staffing gets better and you've done, now it's not your first and second SRS, it's maybe your 30th or your 40th SRS, and you reevaluate your statistics and you can adjust your tolerances and your margins as your skill sets increase and get better and more familiar with those types of treatments. And so now you're increasing your quality and you have a tool to measure what that increase in your quality is. And what that goes to is, again, the way we manage our patients. We're now predicting states in the future rather than just always reacting to states that we saw during treatment. And good examples of that for us, we've all had patients that exhibit weight loss, weight gain, breast patients that exhibit extreme amount of swelling either in or around the surgical site or in sites not relative to the surgical site that we've seen. And so you can evaluate this performance of the system by simply, this is a bladder that has the same volume as a standard breast in our practice. We fill it with fluid, we take the CT, we register it on the machine. We then interactively introduce more fluid or less fluid, and we use the surface statistics tool. The surface statistics tool allows us to see the total quality of the registration of our patient with a rigid registration under a deformable surface condition, so a swelling or a weight loss. And so you can see if I add fluid here on the right, only about 69% of that surface is being registered appropriately. And it then will highlight that surface in red. If you see the bar there, the blue is below. This is on slide 11. If we're not on slide 11, I apologize again. If we're on slide 11, if you look at the image on the right-hand side, there is a blue bar that goes to red. So blue is below the surface, red is above the surface. We use these types of images for our physicians on their weekly management. How many times have you seen a breast film and you say, well, it looks like they're swollen in the upper inner quadrant, maybe it's the upper outer quadrant, we can't really tell. In this case, you have a 3D rendering of the patient, and in this rendering, where it's red is where the patient is swollen. And so we validated this on basically a liquid-filled bladder. If you go to the next slide, slide 12, you can see kind of a scenario where the patient loses weight simulated here. So you remove fluid from the bladder, and now the surface